All right, so now without further ado, we are going to introduce our speaker. We're very, very pleased this evening to have Dr. Erik Zachiwieja, got that right, an orthopedic surgeon, and he will be talking to you about hips and knees. Thank you, doctor.
Thank you very much for having me. I'm going to go ahead and share my screen in just a minute, but I just want to introduce myself first. So my name is Dr. Erik Zachiwieja, and I'm sorry, can
Oh,
everybody
we're
hear me?
good.
Yeah,
You're good.
okay. So I just wanted to introduce myself. My name is Dr. Erik Zachiwieja, and I am a orthopedic surgeon in town. I'm in a private practice of Garden State Orthopedic Associates. And I operate primarily out of Valley Hospital. And my specialty is hip and knees, and with a focus on hip and knee arthritis and hip and knee replacement surgery. So today we're going to have a talk about what is hip and knee arthritis and what we can do about it. So I'm going to go ahead and share my screen now. All right, so hip and knee osteoarthritis, what is it and how can we treat it? Again, I work for Garden State Orthopedic Associates. We're an orthopedic only group in primarily Bergen County. We have offices in Fair Lawn, Paramus, Mahwah, and Clifton, and then also an office down in Hoboken. And myself and the rest of my partners operate primarily out of Valley Hospital. And again, I specialize in hip and knee replacements. So we'll go through the talk, and please, if you guys have any questions throughout the talk, just type them into the chat box, and we will hopefully be able to get to them at the end of the talk, if I don't answer them as we proceed. So first of all, what is osteoarthritis? In general, we need to think of osteoarthritis as damage to the cartilage within a joint. I mean, we're going to focus today primarily on hips and knees, which are actually the most commonly affected joints from arthritis. And so cartilage is that smooth cap on the end of your bone. It's the white smooth stuff on the end of a chicken bone that allows the bones to move to glide smoothly together. And when you lose that cartilage through a multitude of different reasons, that can lead to a multitude of different symptoms. And generally, arthritis is progressive in nature, and it results in pain, oftentimes deformity, and then stiffness or difficulty with movement. And I'm sure most of the people on this talk either themselves or know somebody who is affected by osteoarthritis. It affects over 27 million individuals in the United States alone. So it is extremely common, and it can really have quite a major impact on both quality of life and patients' ability to perform both activities of daily living, meaning things that they require to do on a daily basis, as well as activities that they enjoy doing. And so it really can significantly impact patients and their ability to live a happy, healthy lifestyle. And so the causes for obesity are really multifactorial. There's many, many reasons ultimately for the development of osteoarthritis. But in general, today we're gonna focus on osteoarthritis, which is primarily genetic in nature. We don't always know why patients develop it. One thing that we will touch on, though, is that obesity or being overweight can absolutely contribute to it. So any sort of weight loss will always help your lower extremity joints and reduce the symptoms associated with arthritis. So first of all, how do you know if you have osteoarthritis? Well, in general, it starts off with pain in the associated joint that's worse with activity. So we call that pain-related activity. And then as the disease progresses, you may even begin to feel pain at nighttime. Oftentimes, patients with hip or knee arthritis will wake up in the middle of the night with pain. And then you may also begin to develop stiffness or difficulty moving the joint. And then as the disease progresses, you may develop a deformity within the joint. And then the rapidity at which the disease progresses varies between patients. Sometimes it can develop and progress very rapidly in several months. Other times it can take years and years and years to fully progress. And that really will dictate our management. And as you can see here on this little schematic on the right, nearly 50% of people over 75 years or older will develop arthritis So this is extremely common and something that all people should be aware of, and ultimately understand our treatment options so that we can manage this effectively early to maintain the best quality of life moving forward. So here I have a few schematics of a knee. And so we'll talk a little bit about knee osteoarthritis. And in general, patients with knee osteoarthritis are going to present with difficulty using the stairs, walking, kneeling, or bending. And that's because of this stiffness that develops in the knee, so an inability to bend it fully. And so patients oftentimes may have difficulty getting up from a low chair and things like that. And the knee patients will also often describe that the knee is stiff and painful when they're ambulating. And oftentimes you may notice clicking or popping within the knee. I often describe that to my patients as kind of Rice Krispies within the knee. And that's the knee not gliding smoothly anymore because of the loss of cartilage. And if you look at the picture on the top right, you can kind of see as you lose the cartilage why things may not move quite so smoothly as they used to. There's going to be a lot of ridges and bumps within all the moving parts, which leads to a lot of that crunching and popping and clicking that we sometimes experience in the knee. And then sometimes you begin to develop a deformity within the knee, and so your knees can become either bow-legged or knock-kneed, and that also is a sign of progressing arthritis. Now the hip is a different type of joint. It's a ball and socket joint, so it moves a little bit differently. But in general, as you lose the cartilage, again, you begin to develop stiffness within that joint, so it becomes difficulty bending at the hip. Patients will often describe difficulty bending over, putting their shoes and socks on in the morning. Oftentimes, they also have difficulty getting out of a low car. And in general, hip pain is usually within the groin. Patients will often say that they have hip pain and they point to the outside part of their hip where they feel the bone. And that's actually usually not arthritis. That's more of a bursitis or inflammation, which is much easier to treat than osteoarthritis, which we'll usually feel in the groin. Now, is there a cure for osteoarthritis? Unfortunately, in 2021, we do not have a non-surgical cure for osteoarthritis. If anybody out there can develop that cure, I can guarantee you'll make quite your fair share of money. But unfortunately, in 2021, we don't have a cure yet. So all of our non-operative measures are aimed at treating the symptoms and managing the symptoms. And then we do have surgical options, and that includes both hip and knee replacement, where you basically cut out the affected cartilage, which is the damaged anatomy within osteoarthritis, and you replace it with metal and plastic. And that currently is our only cure for osteoarthritis. Okay, so first of all, how can we relieve hip and knee arthritis without surgery? So how can we manage the symptoms to improve patients' quality of life and restore function? First and foremost, the number one thing we always recommend is exercise and physical therapy. Exercise and physical therapy help increase the range of motion of the joints and improve flexibility. And it can be quite impressive how significantly that can really improve the symptoms associated with osteoarthritis. So particularly in early to moderate stages of arthritis, physical therapy and regular exercise is very, very important. And so that involves strengthening the muscles as well as improving range of motion and flexibility. And in turn, that oftentimes does relieve pain and improve function. Unfortunately, in patients that have developed more severe arthritis, who oftentimes come in with what we call bone-on-bone arthritis, exercise can oftentimes aggravate the symptoms. So this is more of a treatment for mild to moderate disease. In the more severe disease, physical therapy may actually be more of a detriment than a positive effect. But that's something you can talk with your physician about. As I mentioned a little bit early, weight loss. So so you put about 3 to 5 times your body weight through your hip and knee joints when walking or using the stairs. So essentially, every 10 pounds of weight that you lose can be 50 less pounds going through the weight-bearing surfaces of both your hip and knee joints. So even a little bit of weight loss can make a dramatic effect, can have a dramatic effect with regards to your symptoms and osteoarthritis. So I always counsel all of my patients about weight loss, whether they're obese or overweight or not, because maintaining a healthy body weight not only as I mentioned here, can improve your symptoms associated with osteoarthritis, but obviously maintaining a good body weight has a lot of other systemic health benefits as well, as we know from a heart and lung and exercise capacity as well. Now, there are also a multitude of different types of medications that we can use for the pain associated with osteoarthritis. So in general, the pain associated with osteoarthritis is primarily related to inflammation within the joint. So we recommend anti-inflammatory medications. So these are both over-the-counter, such as Aleve, which is naproxen, or Motrin or Advil, which are ibuprofen. Or Tylenol as well is beneficial. And oftentimes patients who are on any sort of blood thinners, we would recommend Tylenol, because adding an anti-inflammatory with a blood thinner can increase your risk of bleeding. So in the older population, there are many patients on blood thinners. So in that cohort of patients, Tylenol is an excellent choice. We also have prescription strength anti-inflammatories, which act in a similar manner to the over-the-counter medicines, just with a little bit extra strength. And those are going to be medications such as meloxicam, or Mobic, or Celebrex, which some of you may have heard of in the past. Now, we also have local injections that we can offer to patients with both hip and knee osteoarthritis, which can provide relief. So injections are essentially a very potent anti-inflammatory injected directly into the target area, so they can have a much more local effect rather than a systemic effect, which our oral anti-inflammatories provide. And so typically the first line of treatment are cortisone injections, or which is a steroid injection. This is very similar to the same type of thing that athletes get in their joints, or you may have gotten in your shoulder or multiple areas throughout the body. And they can be very, very effective at providing pain relief and reducing inflammation. Unfortunately, they typically won't improve your range of motion. So if you have developed stiffness, that may not improve, but pain relief is the #1 goal following a cortisone injection. Now, how long this lasts is a very common question that I receive from patients. And it's a tough question to answer, or a tough question to answer, because it can really vary between patients. Some patients can get significant relief up to 6 months or a year. Other patients only a few weeks up to a few months, and we really don't know that until we try. The good thing about cortisone injections is that they are very low risk with very, very minimal side effects, and they're very safe. Occasionally, they may make you a little bit more sore for a day or two, but after that, the medicine usually kicks in and provides some good relief. Unfortunately, they do typically follow the law of diminishing returns, meaning that the more injections you do have, typically they become less and less effective. So they're not a good long-term treatment option, but they definitely are very good in the short term. Another type of injection option that we have are called viscosupplementation injections, also called gel shots, you may have heard, which essentially is comprised of hyaluronic acid. And this is essentially the material that our joint fluid is made out of. So I describe viscosupplementation injections essentially as injecting an artificial lubricant into the joint. So it acts similar to a motor oil to help the parts moving smoothly. Again, this does not cure arthritis. It is a temporary relief measure. In general, in the earlier stages of arthritis, it can provide pretty good relief, though, but oftentimes up to 6 months or even a year. Again, these are very safe with minimal side effects. The only real side effect we worry about is occasionally patients may be allergic to some of the components within the injection. And if you are, it's usually a very mild response that can be treated with over-the-counter anti-inflammatories. These oftentimes as well follow the law of diminishing returns, meaning the more often you have them done, the less efficacious they are. So these are good for a few times early in the disease process, and they can be very effective. Another non-operative treatment option, this is primarily focused on knee arthritis is something that we call a genicular nerve ablation procedure. So that's kind of some very fancy terminology for meaning basically burning the nerves around the knee joint that provide sensation. So if you get rid of the pain source coming from the knee and that sensation, then you should have a pain-free knee. Again, that's not going to relieve the stiffness associated with it, but it may provide some pain relief. Unfortunately, in general, usually the nerves do regrow after 3 to 6 months. And so this is another temporary measure, but it again can provide some temporary relief for patients looking for a way to manage their pain before a more definitive solution. Okay, so those are pretty much all of the non-operative treatment modalities that we have for hip and knee osteoarthritis. And again, they can be very, very efficacious in the early stages of disease. They can provide quite significant relief for patients and improve their function and quality of life. Now, at what point do you need to consider surgery? Well, basically, have you gone through and tried all of the things that we just discussed? Have you tried physical therapy, a home exercise program? Have you lost some weight? Have you tried anti-inflammatory medications? Have you tried injections? Have you tried a nerve block plus or minus? If you've gone through all of those things and you're still affected, your joint still bothers you, you're unable to do the things that you want to do, that you need to do, that you enjoy doing, and your quality of life is affected, then it's time to consider a more permanent solution. And in general, I typically tell my patients that they're going to know when that time is right. They've gone through all of the non-operative measures. They're really just not happy, and they can't do the things that they enjoy doing on a daily basis to maintain their quality of life. Then they know that the time is right to proceed with something more definitive. And the good thing about proceeding with a more definitive solution is that we have very good options. And so first, we're going to start talking about knee replacement. So obviously, that's going to be for patients who have osteoarthritis of the knee that has failed all of the non-operative measures that we talked about, and they continue to be quite symptomatic on a daily basis with a painful, stiff knee that doesn't allow them to do the things that they enjoy doing. In that scenario, it's a very reasonable option to consider a total knee replacement. So I just want to go over the basics of what a total knee replacement is, what you should expect, and how it works. So first off, how long does a total knee replacement surgery take? Well, in general, it takes about 1 to 1.5 hours. So most patients come in the day of surgery. They're there for about an hour to an hour and a half before surgery. The surgery itself takes about an hour to an hour and a half, and then you're admitted to the hospital. Do you have general anesthesia? In almost all cases, we no longer use general anesthesia for knee replacements. We now use regional anesthesia, also called spinal sedation or an epidural, similar to what females get for childbirth. And that essentially just numbs the body from the legs down. And that is significantly better than general anesthesia because it reduces the side effects of general anesthesia, which are nausea, urinary retention. And then additionally, it allows patients to be up and moving and out of bed sooner, which is our primary goal following joint replacement surgery. We want patients to be up and walking the same day as surgery. My patients are usually out of bed walking within 2 hours after surgery. With physical therapy, they're up using stairs either the same day or the very next morning. And spinal anesthesia really has enhanced our ability to do that because patients are no longer drowsy from the general anesthesia. Now, how long will you be in the hospital following a knee replacement? In my particular case, for my patients, about 75% of my patients stay in the hospital one night. Then they go home the following morning. Occasionally, in my younger, healthier patients with a good social support at home, they're actually able to go home the same day as surgery. And that's quite different than the traditional thought process about joint replacement. If we look back about 10 years, most patients were staying in the hospital 3 to 5 days. So we've definitely had a paradigm shift, and we're getting patients out of the hospital sooner and moving quicker, which ultimately is enhancing and speeding their recovery. Now, how long does it take to recover? Now, that's a little bit of a loaded question because it depends what the ultimate goal is afterwards. But in general, I like to tell patients that you should expect to be walking with a cane or an assistive device for about 2 weeks following surgery. By 6 weeks, you'll be walking pretty much normally. You may have a slight limp. You might have still some mild swelling in the knee, but overall, you're able to ambulate quite well. And by 3 months, you're about 90% recovered. So you may have some very mild limitations, but in general, you're able to do most things with no real side effects or limitations. It may take 1 full year to achieve 100% recovery, but by 3 months, you're almost there. Patients will often ask when they can return to work. If you have a sedentary job, you can usually return to work by 2 to 3 weeks. If you have a more labor-intensive job, it may be closer to 3 months. When can you drive? So that's going to depend and be very patient dependent, and also depend on which leg was affected. If it's the left knee, patients could drive at probably 1 to 2 weeks. If it's the right knee, probably closer to 3 to 4 weeks. As I mentioned, when can you return to work? A sedentary job, usually even in less than 3 weeks. And then a more demanding job is going to be probably closer to 2 to 3 months. Will you need physical therapy afterwards? And the answer to that is yes. So for all of my patients, they go home the day following surgery. Then they have home physical therapy for the first 2 weeks, meaning a home health aide comes to the house 5 times a week for 2 weeks, and does basic general exercises to improve your range of motion and your strength. And then for the following 6 weeks, you go to outpatient physical therapy. And by 8 weeks after surgery, most patients don't require any more therapy after that, as they've now regained near normal function of the knee. Another common question I often get is how long will the joint replacement last? I really like to think about that in terms of the failure rate of the joint replacement. So in general, the failure rate of a joint replacement, both hip and knee, is about 0.5 to 1% per year. So what that means is about 20 years following your joint replacement, you still have an 80% chance that you have a well-functioning joint. 30 years following your surgery, there's still a 70% chance of a well-functioning joint. So if we look at our data, the vast majority of patients, or the vast majority of implants, will outlive their patient. So most patients will pass away with the implant that was initially performed. What will my new knee feel like? So it's very important to understand that the goal of knee replacement surgery is to provide a better functioning version of your current knee. So most patients will not get a knee that functions like a 20-year-old marathon runner's knee. It's going to give you a pain-free functional knee, meaning you're able to perform most activities of daily living with no limitations and in a pain-free manner. You may not be able to run several miles, or regain full motion, meaning being able to do full yoga poses after a knee replacement. We hope you can, but that's not always possible. Really, the goal of knee replacement is to give you a better pain-free functioning version of the knee that you have before surgery. And then one thing I just want to highlight is particularly at Valley, we are able to perform robotic assisted knee replacement, which is kind of the newest technology within the orthopedic joint replacement space. And it really has allowed us to very precisely implant our joint replacements in a way that provides patients the quickest recovery, the most longevity with regards to the implant, and in the most minimally invasive way possible. And so it really has been a revolution in the joint replacement world. And Valley Hospital actually has 3 robotic assisted machines that allow us, basically all of the surgeons at Valley, to use this technology very effectively. And it really is a tremendous new technology for us. And here we just have a depiction of how we're able to, in 3 dimensions, see exactly what we're doing on a screen and live, and perform very precise shaving of the cartilage, which is what we remove before replacing with metal and plastic. And here I just am showing that with robotic assisted technology, which again, we perform nearly all of the surgeons at Valley Hospital. We can see that patients have a significantly higher, what we call forgotten joint score, which I think is quite interesting, meaning that if you ask patients 2 years after surgery, can they remember which knee was replaced? There's a much higher percentage of patients that can't in the robotic assisted arm, meaning that patients are doing so well they can't even tell the difference between their replaced knee and their native knee. All right, so that was total knee replacement. We'll talk a little bit now about hip replacement. And again, a few of these things are going to be pretty similar. So hip replacement also takes about 1 to 1.5 hours, a relatively routine and quick procedure. And we use general anesthesia, or we use spinal anesthesia, sorry, not general anesthesia. Again, with the goal of reducing nausea, urinary retention, and ultimately allowing patients to be up and walking as soon as possible after surgery. So just like knee replacement, following hip replacement, my goal is to have patients up and walking within 2 hours, using the stairs, doing all of the physical activity that they're ultimately going to need to do when they go home. Again, most of my patients stay in the hospital one night. About 20 to 25% of my patients do go home the same day. And again, those are the healthier, usually less than 65 and younger patients with good family support at home. Now, a very common question with regards to hip replacement is the surgical approach. I utilize a direct anterior approach, which is often referred to as a muscle-sparing, minimally invasive approach. And the reason for that, the reason that I use it is really twofold. Number one, it's less painful than the more traditional approach, which is through the back of the hip. And that is because I do not have to cut any muscle or tendons off of the bone, which actually is quite painful. So through this muscle sparing approach, we're able to just go between the muscles and we don't have to cut anything off of the bone. And then additionally, it allows for a smaller incision, so minimally invasive. And it allows for a quicker recovery because we're not cutting the muscle and tendon off of the bone. Patients have less pain. They're able to get up and walk earlier, and they're able to move quicker. And here is just a depiction of the size of the incision. So this is in the direct anterior approach. It's about 3 to 4 inches in length, and it's on basically the front of the hip. And there's actually even a technique where we can do what's called a bikini incision. So we can make the incision in line with your your hip flexion crease. And if you can see there, that picture in the middle, you actually can't even see that patient's scar because it's so nicely within the hip flexion crease. And then there's just a surgical image on the right showing the size of the incision. It's quite small. Now, how long does it take to recover from a hip replacement? So in general, hip replacements are a much easier recovery than knee replacements. And typically it's about half the time for recovery as well. So you should expect to walk with a cane or an assistive device for about 1 to 2 weeks. In general, when patients come to see me 2 weeks following surgery, they're walking without any assistive device. You go for about 6 weeks of physical therapy, and by 8 weeks, most patients feel pretty darn good and are getting back to doing all activities with no limitations. and this is somewhat anecdotal, but I think one of the most common things that patients say to me when they come in for their 2 or 6 week postoperative visit following a hip replacement is they'll oftentimes say, "Doc, the one thing I really, really regret about this surgery is that I didn't do it sooner," because hip replacement really is a life-changing surgery, and the recovery is so mild that patients regret that they didn't do it earlier and really see those benefits as soon as possible. Again, with regards to driving, it's usually about 2 to 4 weeks, depending on the operative side, a little bit longer if it's your right leg. Returning to work following a hip replacement. Again, if you're sedentary, it's going to be probably 2 to 3 weeks. If it's more demanding, it may be closer to 2 to 3 months. Will I need physical therapy? If my patients are motivated and they have good support at home, they do not necessarily need physical therapy. Really, all you have to do is walk regularly and do some basic exercises around the house, and the recovery from hip replacement is actually pretty quick. Patients who maybe aren't so motivated or need a little extra push in the right direction, I will send to physical therapy, but it's not something that all patients require. And then, this is going to be the same discussion with regards to how long the implants will last. Both our hip and knee replacement implants are made out of the same materials, which is a forged titanium with highly cross-linked polyethylene, which is a very wear-resistant type of plastic. And so how long the hip replacement will last is the same as a knee replacement, about a 0.5 to 1% failure rate per decade. What will my new hip feel like? So in contrast to a knee replacement, most patients after about 1 year will not be able to recall which hip was replaced, meaning their forgotten joint score is very, very high. So a hip replacement really restores all function in the hip with no limitations, and patients often cannot even tell the difference between the affected and the non-affected hip. Now, one last thing I just want to touch on is this idea of, is a joint replacement worth it? So a common way to measure the value of a procedure in orthopedics is to compare the cost of the procedure to the quality years of life it gives to a person. So even though the cost of a joint replacement is high, the improvement to the quality of life, and particularly when we plot this out over the patient's their lifespan, their quality of life years is significantly greater than the overall cost of the surgery in that one episode of care. So in general, the costs are quite low. And if you ask when you do large type cohort studies and ask patients would they have their joint replacement again, about 90 to 95% of patients state that they would go through with that same surgery again because of the improved quality of life and excellent outcome that they received. So that's kind of my spiel on hip and knee osteoarthritis and how we can manage it from both a non-operative and operative way. I'm sure there's lots of, or I hope that there's some questions out there that I would, be very willing to answer. And if there's anything that I left out or didn't touch on, please let me know so I can help.
Okay. Thank you, Dr. Zachiwieja. We do have a few questions for you. One question is regarding stem cells to rejuvenate the hip. Is this effective? Is this something you would recommend?
So stem cell therapy for both the hip or the knee or many other joints is in its very early phases of understanding. And at this point, we do not have any firm data to show that it is truly effective or better than placebo. So we have very little data to show that it's harmful, but we have no real data to show that it actually can improve symptoms associated with osteoarthritis. In fact, we have no data to show that it's any better than placebo.
Okay, thank you. Are there benefits of having surgery at the onset of osteoarthritis versus having injections first?
In general, I do not recommend having surgery in the earlier in the earlier phases of the disease process, because the non-operative measures can be quite effective. And for some patients, they can be so effective that they are able to delay or prolong the progression of disease to the point that they never need a joint replacement. And the other thing is that if we look at a lot of our data and literature, patients do not tend to have as good of outcomes if they have surgery on the hip or the knee before they have bone-on-bone arthritis. So very, very rarely will I recommend going through with a joint replacement until you've developed bone-on-bone arthritis. The only caveat to that would be patients who are maybe a little bit older and sicker and are their medical comorbidities may limit them from going through a big procedure later on in life. So electing to go through with the procedure while the medical comorbidities are kind of being managed appropriately prior to the progression of other medical diseases. But in general, you should wait until you at least have bone-on-bone arthritis before proceeding with any sort of surgery.
Okay. How do you control the pain after surgery? Are opioids avoided?
Yes, that's a great question. So I use a cocktail of different pain medications with the goal of avoiding narcotics. And so I target the pain pathway from multiple different ways. So I use extra strength Tylenol as a pain reliever. I use a very strong oral anti-inflammatory. I use a muscle relaxant. I use a nerve pill. We also use what we call local anesthesia or a periarticular nerve block, which is where we inject medicine locally around the joint. All of these with the goal of reducing narcotic consumption. I do provide patients a small amount of narcotics after surgery. About my hip patients, about 50% of them don't use narcotics at all. My knee patients, typically I prescribe them about 15 narcotic pain pills, and most patients don't finish them.
Okay, this question is a little more involved. This person wants, her dad is 84 years old, and she wanted to know about how do you replace knees in the elderly and what are the outcomes?
Mm-hmm. Yeah, so in general, age is just a number. We really think about it more of their physiologic age than their chronological age. So you can have a 95-year-old patient who is healthy and active, and they can be, and compare that to a 65-year-old patient who has multiple medical comorbidities. And in general, I'd be much more enthused to operate on the 95-year-old who's healthy and active than the 65-year-old. So first of all, you don't always look at just the age and the number, but you have to look at their physiological status as well. But in general, we are still able to very safely and effectively perform joint replacement surgery in octogenarians or even nonagenarians, so 80 and 90-year-old patients, as long as they're medically fit for surgery. And in fact, these patients typically actually have better functional outcomes than the younger patients, and that's because they're a little bit lower demand. So they're not expecting to do quite as much with their joint replacement as, say, a 55-year-old. And so they're quite functional and able to get around and do all of the things that they need to do very safely and effectively. And so as long as the patients are medically optimized prior to surgery, then it's very safe and we're very effectively able to perform the surgery.
Is back pain when walking associated with hip problems?
I'm sorry, was that back pain?
Yes.
It could be. So back and hip pain oftentimes overlap, and it's sometimes difficult to assess and truly understand where the pain is coming from. In general, hip pain is more associated with, or hip issues is more associated with groin pain, but it can sometimes be referred to the lower back. But that's something that needs to be assessed on an individual patient by patient basis.
Okay. This person is very motivated. After 8 weeks of therapy, is there a maintenance program for knee replacement? And what about returning to the pickleball court?
Now, so is this before surgery, before knee replacement or after knee replacement?
I'm thinking after.
Okay, yeah. So typically following knee replacement, we do 6 to 8 weeks of physical therapy. And then it's really just a home exercise program based on the exercises that you learned in therapy, and then gradually resuming activities as tolerated. Um, Returning to pickleball is a very, very reasonable goal. Most patients can probably get back to that type of activity between 4 and 6 months following surgery. I don't give my patients any limitations with regards to what they can and cannot do. And that's really because the goal of performing this surgery for me is to restore patients' quality of life and return them to doing the activities that they enjoy. So I allow my patients to do anything that they safely and effectively can do. Pickleball is a very reasonable activity to be able to return to.
Just one more question. Is PRP therapy at all helpful in reducing arthritic pain in the knee?
So PRP, that refers to platelet-rich plasma, which is basically when you take some of your own blood and then we spin it down in a centrifuge to collect all of the very nice anti-inflammatory properties that are within our own blood, and then we re-inject that back into the joint. Now, similar to what I had mentioned about stem cell therapy, unfortunately, within the hip and knee arthritis literature, we don't have any evidence that that's any more efficacious than corticosteroid injections for pain relief. Now, there are other types of ailments that PRP has been shown to be quite effective for. With regards to hip and knee arthritis, we don't have any evidence that it's any more efficacious than corticosteroid injections. That doesn't mean that it won't help you, but it's not any better than some of our other options.
Okay, I want to thank you, Dr. Zachiwieja, for joining us this evening.